Good evening. My name is Stacy Lazar, Practice Administrator for the Cornea and Laser Eye Institute and the CLEI Center for Keratoconus. I'd like to thank everyone for taking the time out of your evening to take part in our webinar tonight. Tonight, we will be discussing corneal tissue addition for keratoconus, otherwise known as CTAK, in a clinical trial. As always, please feel free to share our webinar invites to anybody that you know that either has keratoconus, in keratoconus support groups, or just anybody that might be interested in learning about KC. We will be holding off all questions until the end. During the presentations by Dr. Hersh, Dr. Greenstein, and Dr. Gellies, if you have a question, please type it in the question box below, as audio will be muted. We've allotted 1 hour for the seminar, but if we run over, depending on the number of questions, that's okay. We might run a little bit over. That being said, if we do not get to answer your specific questions tonight, please feel free to email your question to our office at info@vision-institute.com. On that note, I am going to hand the presentation over to Dr. Stephen Greenstein.
Thank you, Stacy. And as Stacy said, we're really excited tonight to be presenting on this topic. It's a novel procedure which is really at the forefront of keratoconus management. And so we're excited to present on customized tissue addition for keratoconus, or CTAK. So as Stacy mentioned, and many who are joining us are returning from previous webinars that we've hosted, but we work out of the CLEI Center for Keratoconus, which formally started in 2002. Dr. Hersh has been the director of the Center for Keratoconus since then. He was the medical monitor for the multi-center FDA cross-linking trials. And our center is really dedicated to both the research and treatment of keratoconus. So again, this for many people is a brief review, but what is keratoconus? Keratoconus is a progressive disease. It comes from a focal corneal thinning. The thin portion of the cornea is weaker than the rest of the cornea, so there's a loss of biomechanical strength. And because of this weakening, the cornea begins to steepen and become more irregular. This irregularity distorts optics and distorts vision. And that's really the main problem for patients who have this disease. Now, in general, we like to sort of use this analogy when talking about keratoconus, and we compare it to a tire on a car. And in the top left, you can see a picture of a normal cornea, which is symmetric on the top and the bottom, and this is very similar to a normal tire. If you inflate a normal tire with air, the tire is going to inflate symmetrically all the way around. Similarly, if you have a thin portion of that same tire, most of the tire is going to inflate the same, but the thin portion is going to bulge away from the tire and become irregular. And if you look at the picture on the bottom left, that's exactly what happens to the keratoconic cornea. The areas of thinning are weaker, and so they begin to bulge away from the rest of the cornea, creating an asymmetry, mostly from the top to the bottom. Now, this is where CTAK, or customized tissue addition for keratoconus, really is a novel tissue addition technique to treat this disease. And the addition component of this is really crucial because different from a lot of the other treatment options we have, we're actually adding corneal tissue. We're adding and thickening the thinning portion of the cornea, and thereby also improving the corneal shape and improving visual acuity. So this procedure was originally started as part of a clinical trial, which actually began in 2016. And this was really when the first iterations of adding corneal tissue to keratoconic corneas began in our center. It's gone through multiple iterations, which has really brought us to the presentation tonight, which we're really excited to present on this customized tissue addition, and to kind of take you through that journey that we went through and how we got here today. So to take a step back, when it comes to keratoconus management, there's really three critical components to keratoconus management. The first is, of course, stability. We want to keep the cornea from getting worse. We want to stabilize the disease at the point that it is currently at. The second is that we want to improve corneal shape. So inherently, the cornea is an irregular shape, and there are procedures that we can offer to improve that shape. And finally, once we've stabilized the cornea and we've improved the corneal shape, we can then correct the remaining prescription in your eye. So for stability, we still really have one main procedure which stabilizes the cornea, and that is corneal collagen cross-linking. Many people have heard us present on collagen cross-linking in the past. There's many new and exciting things happening with cross-linking treatment, which we hope to present on in the future, but it is still the mainstay treatment to stabilize the cornea. In terms of reshaping the cornea, we have multiple procedures available, and this is an expanding area. Intacs being one of them, topography-guided PRK using a laser to reshape the cornea, conductive keratoplasty, which uses thermal energy to reshape the cornea, and now CTAK, using preserved corneal tissue added to the cornea to reshape the cornea. So the procedure is designed to improve corneal shape and hopefully improve vision after that. And finally, the third component is once the corneal reshaping is complete, we still then need to correct any remaining prescription. And that might be with glasses. It can still require specialty contact lenses. There are certain patients who can then move forward with a laser correction that may continue to improve the vision, and other intraocular or inside the eye procedures, such as the implantable contact lens, which can improve your vision further. So diving into the CTAK procedure itself, one of the most common questions that were asked is this a corneal transplant? So to answer that, we sort of need to discuss what is involved in doing a traditional corneal transplant. And a traditional corneal transplant is really a replacement of diseased corneal tissue with donated corneal tissue. And this can come in multiple forms. So the most typical transplant that you'll hear of is a full thickness corneal transplant, and that involves removing the entirety of the cornea in a specific location from the top to the bottom, and then replacing that area of the cornea with donor tissue. More recently, we are now able to replace only specific layers of the cornea. So we can actually replace just the diseased areas of the cornea, and that can be the top areas. So we can replace the top areas of the cornea, and we can replace sometimes the bottom areas of the cornea. And these allow us to replace much less tissue than a full transplant, and there are certain benefits to that, which we'll go into in a little bit. The CTAK procedure really is not replacing corneal tissue, but it's adding a preserved corneal tissue to reshape the cornea. And the way that works is, this is sort of our diagram that we created to try to explain this process a little bit better. So what you're looking at on the left would be a side view of the cornea. And the keratoconic cornea has that irregularity to it, or the cone shape, usually at the bottom. In the CTAK procedure, we will then create a laser channel, which is indicated by the white circle at the bottom. That channel will then be filled with a preserved corneal tissue, which adds thickness to the cornea and thereby flattens the cornea, decreasing the irregularity and decreasing the cone. So what is this preserved corneal tissue that I've been discussing? Specifically for the upcoming trial, we're going to be using a preserved gamma irradiated corneal tissue. It's provided, it's called vision graft tissue. It's provided by CorneaGen. And one of the main things that you can see from the picture below is that on the right is a normal, fresh corneal tissue specimen. And even after this gamma irradiation process, you can see that on the left, the tissue structure is maintained. So the irradiated tissue maintains a healthy structure, which can then be inserted into the cornea. What does it mean to preserve the corneal tissue? So this is done in a few steps. The tissue is harvested from a donor, as any corneal tissue would be. It meets all of the criteria that have been set by the Eye Bank Association of America. The tissue is then frozen, which actually inactivates all of the cells, and Dr. Hersh will discuss a little bit later why that's important for this type of corneal tissue. And then once the gamma irradiation process is complete, the tissue is sterilized. So we hope by removing these cells and sterilizing the tissue, we decrease any chance of any bacterial or fungal components that can be associated with corneal tissue and infections, as well as any kind of inflammatory response. And again, Dr. Hersh will go into that in a little more detail as we move along tonight. So this tissue is really ideal for adding to a already thin cornea in keratoconus. Now, the second really important component to this procedure is the customization. So this is a customized tissue inlay. And so for most keratoconus procedures that we do, the cornea needs to be a certain thickness. If the cornea becomes too thin, many of the procedures that we currently have, we can't offer to reshape the cornea. In this case, this tissue can be customized even for thinner cornea. So traditionally for corneas that we were unable to treat with other procedures that we had available, the CTAK procedure can work even in thin corneas. In addition, the area that we treat, the cone area, that steep area that we want to flatten, has to be in a location that we can access with a particular procedure. So for Intacs, it has to be accessible with the Intact segment, or for topography guided PRK with the laser. But with the CTAK procedure, we can really customize the tissue to fit around any cone in any area of the cornea, and we'll see some pictures of that in a little bit. Furthermore, with the procedures that we have, the steepening can sometimes limit our ability to perform the procedure and flatten the cornea in a meaningful way. And once again, the customization of this procedure allows us to induce more flattening, but not just more flattening, it allows us to modulate how much flattening we want to induce to get the result that we're looking for. So how do we do this customization? Everything starts with mapping out your cornea, and we have multiple devices in our center which will map out your cornea to get an exact model of the curvature and elevation of the cornea before we move forward with the procedure. And you can see in the picture on the right, it's a pretty typical procedure we'll generate with our Pentacam topographer. The top left picture shows a typical curvature map of somebody with a more moderate to sort of early severe keratoconus, where the cornea is very steep in the center, that's the pink and the red areas, and then flattens as you get towards the outside portions of the cornea. You can see in the picture on the top right that that area is very elevated, which is highlighted in the maroon, and also in the bottom right. And then the cornea is also fairly thin, which is the red maroon areas in the bottom left. The next thing we do is we further map out the cornea to determine the location and size of the cone. What we've learned over time is that patients' area of steepening, the cone, can be variable in size and location, and it's really important to be able to map exactly where and how large that area is to be able to get an effective treatment. And one of the things that we've done, and Dr. Gellies was a major contributor to this portion of things as well, as it has a lot of ramifications for contact lens fitting, is we look at these elevation maps of your cornea. And the purple areas are where the cornea is depressed, the steeper areas, and the maroon areas up top is where the cornea is elevated, and the flatter areas. And what we want to do, as we showed in the diagram before, is raise those depressed areas. So if we highlight the entire purple area, and we can create a segment of exactly that size and in exactly that location, we are able to reshape the cornea in a more customized way. And so here's some examples of that customization. On the left is a patient with more moderate keratoconus. The pink area is a little bit off center. And on the picture on the right, you have a patient with a little bit more severe keratoconus, a larger pink area, which is a little steeper and a little more central. So how can we treat these two different sized cones and cones in a different area with the same treatment? Well, the next step is we look at those elevation maps, and this really highlights how different these corneas are. In the case on the left, the area of depression is very much located off center, and in the case on the right, the areas of depression really wrap around the entire center of the cornea. Well, now we can take our customized corneal tissue and we can place it in exactly the location that we want. So if you look at the pictures of the purple areas where we want to place the tissue, and now where the tissue is placed, you can see how different the tissue can be cut or prepared so that we can get the desired result. Now, how does the procedure actually perform? There's three components to performing the CTAK procedure. The first is the tissue shaping and preparing the tissue for implantation. And we do this with a femtosecond laser. This is the same laser that's used to create LASIK flaps, and it can create very precise cuts on the cornea at the exact angles and in the exact location that we want to prepare the tissue. And the video on the left is exactly how the tissue is prepared. The laser is making the cuts at the desired width that we want with the desired diameter that we want. And then we can further cut the tissue to create this crescent that you see in the picture on the right at the exact length that we want to fill the area. The second is we need to create a channel in the cornea with the same laser for tissue implantation. And the great thing is that we're using the same laser to prepare the tissue as we are to cut the channel. So the channel that we cut is exactly the same size as the tissue that we're preparing. So it's a kind of perfect lock and key sort of fit that we've always been looking for keratoconus procedures. This is done in the office with numbing drops. You don't feel this process happening at all, and it's a very precise procedure. Then finally, we'll implant the tissue in the location that we want. And here's a few different tissues that we've already implanted. You can see that they're all a different size. They're all placed in a different location, really based on each patient's corneal shape and each patient's cone to get the desired flattening that we're looking for. There is a stitch that's placed in the eye immediately after the procedure, and it's removed at 1 week after the procedure is done. So we keep talking about that this is a shape-changing procedure. And this is an example of that shape change that we can induce. So what you can see, and this is a patient who we treated with CTAK, that before surgery, there's really a large pink steep area. This is the cone, and it extends all the way into the center of this patient's vision. Now, after the CTAK segment is placed, what you can see 6 months later in the picture on the right is how much smaller that cone is, how much flatter that cone is. And when we look at the difference map, you can see all the blue areas are the areas of flattening around the cone. So you can see we've really gotten a considerable amount of flattening, all centrally located exactly where we want, with a maximum flattening here of just over 20 diopters. Diopters are our measurement of curvature, and a flattening by 20 diopters is vastly more than we've seen from any other of the procedures that we currently have available. So that's sort of the introduction to how CTAK is performed, how we got to where we are today. And Dr. Hersh is now going to discuss our most recent outcomes from the procedure so far.
Well, thank you, Dr. Greenstein. Welcome, everybody. For those of you on the East Coast, I hope you're enjoying the snow and have managed to dig yourselves out, or not, or enjoying a nice fire while you're listening to this webinar. We've been doing CTAK now for the past 5 years, and as Dr. Greenstein suggested, we've gone through many iterations developing the program to give us the kinds of outcomes that we're getting today. You recollect that Dr. Greenstein just showed you this patient before and after surgery, how we can really lead to some dramatic shape changes and smoothing of the cornea, which, as you know, in keratoconus can be quite distorted. So let's look at CTAK versus something like Intacs. We like to use Intacs for a number of our patients, depending on their specific problems. You recollect that an Intact is an intracorneal ring segment. It's made of polymethyl methacrylate, which is a similar material to a contact lens or an intraocular lens. And they come in sizes. 350, 400, 450 microns is the thickness of these segments, but they're all the same dimension. If you use a thinner Intact segment, one can get a flattening of the cornea of about 5 diopters. Now, a diopter is how the steepness of the cornea is measured. A normal cornea has a power of 42 to 44. A keratoconic cornea usually has a power of 47 or more. So if we ever see a patient just in a normal examination who has a power of 47 or more, we start to get suspicious of keratoconus. Now, indeed, some keratoconic corneas can go up to 80, 90 diopters. Intacs at 350 can flatten the cornea 5.5. If we use a 400, about 7.5. If we use a 450, about 9.5. And these are all averages, and they vary with the degree of keratoconus that we're treating. But if you look well on the right, you can see that CTAK averages about 15 diopters. So we're getting a lot more flattening and a lot more regularity in worse keratoconic eyes than we are able to do when we treat with Intacs. Now we can also customize the dimensions of the CTAK. We can vary the thickness, we can vary the shape, the contour, and how much of the cornea it covers. So some people are going to need more than others, and these are individual patients The ones on the left, the 3.6 and 4, only needed a little bit of flattening. And as you travel down to the right, we have some very severe patients who had upwards of over 20 diopters of flattening. So a substantial degree of regularization of the cornea. Now, the goal of CTAK is manyfold. Number one, we want to improve your vision. Vision can be looked at as vision naked without glasses or contacts, vision with contact lenses, or vision with glasses or spectacles, which we call best spectacle corrected vision. And usually what we're looking at is uncorrected vision and best spectacle corrected vision. Here you can see that on average, both improved by about 4 to 6 lines. The best vision improved from 2160 to 2070, the uncorrected vision from 2500, which is bigger than the big E, to 2120. You can see it more clearly here. On the left without glasses, the average patient couldn't read HVZDS, but when they were done, they could read CZH. I can't read it myself. I must need to undergo an eye examination. CZSHN. Similarly, on the other side, you can see at the end of the day, these patients are able to see a lot better between KDNRO and ZKCSV. If we look at individual patients, there's more improvement as we go to the right of this graph. And most patients improve by a substantial number of lines on the visual acuity chart. With glasses, similarly, most improved substantially. Now, it obviously varies from patient to patient and the degree of problem that you have to start, but generally patients are noting substantial improvement. Again, you need to be well selected and an appropriate person to have CTAK done. But if you are a proper candidate, the benefits can be great. Okay, let's compare CTAK to other keratoconic type of surgeries. First, collagen cross-linking. People often confuse the goals of these different procedures. The goal of collagen cross-linking is to make the cornea stronger. It uses ultraviolet light and riboflavin. Riboflavin is a vitamin that absorbs the light, and when it does this, it causes a chemical reaction within the cornea, leading to linkages between the molecules within the corneal structure. You can think of it as adding extra wires to a suspension bridge to make the bridge stronger. The goal of it is not to improve vision. It's not to improve corneal curvature. The goal is simply to stabilize the cornea. However, there is some slight improvement. Uncorrected vision improved a little bit less than a line in the study that we ran. Corrected vision improved by 1 line. And the corneal curvature improved by about 2 diopters. Now, with Intacs, we had a little more improvement in uncorrected vision, about 1 line of corrected vision improvement, and a corneal curvature change of about 9 diopters of improvement. So that's about as much as we go. If you look at the right, looking at our CTAK patients, you can see a much more robust improvement in the naked vision, the corrected vision, and we can get changes in corneal curvature up to 25 diopters. So that's useful in patients who may come in with a more severe keratoconus of a 75 diopter or 80 diopter elevation. Again, not all patients are candidates. You need to be carefully analyzed and selected. And there are some risks of the procedure. The first is infection. With any eye procedure, any eye operation, there is a risk of infection, as there is with this. We give you antibiotics after the procedure. So the risk is small, but as with any procedure, it exists. Inflammation and scarring can always occur. You're given a corticosteroid drop to prevent the inflammation afterwards. Sometimes it just doesn't work. The corneal shape doesn't improve to our liking or may even make it worse. But the advantage of the CTAK in this kind of case, over and above other kinds of procedures that are not reversible, we can remove the tissue, and in some cases can replace the tissue with something that conforms better to the corneal shape than the first iteration. So we can learn from what we did before. People always ask, can the CTAK inlay have graft rejection? You've all heard of graft rejection and graft failures in corneal transplants, just as there can be graft rejection when you get a kidney. Your body can reject a transplant when you get a corneal transplant. The risk of a graft rejection with a regular corneal transplant is about 10%. The risk goes way down with a partial thickness transplant. A DALK is a deep anterior lamellar keratoplasty. Kera means cornea, plasty means fix it. So we're trying to just use a front part of the tissue in the case of keratoconus to make your cornea smoother. And in these cases, there's about a 5% risk of graft rejection. In CTAK, there probably is a much less rejection rate because there are no cells in the CTAK tissue, and it is made only of natural corneal collagen. The superficial cells are removed, the interior cells are removed, and the cells within the corneal collagen are removed by both the freezing and the gamma irradiation. Indeed, there have been experiments in the laboratory done, and this group found that the corneas remained transparent and there was no immune reaction that might cause graft rejection. In our experience, we've had no cases of graft rejection to date. Our longest follow-up has been now almost, it says 3, but now almost 5 years. And again, we can remove and even replace tissue in many cases. Now remember, after CTAK, there's still going to be a remaining prescription. We certainly hope that you're seeing better, but most of the time, you require glasses, a contact lens, laser treatment, which we call topography-guided PRK, which we use in a very judicious fashion to reshape the cornea in selected keratoconic patients. And as Dr. Greenstein said, implantable lenses, which are used when you still have a high degree of nearsightedness. So let's look at an example of a typical CTAK case. This is a 47-year-old man on whom I did Intacs and cross-linking many years ago. Haven't seen him for a while. He comes in with worsening vision. Says over the years, the vision has gotten really bad, and he's unable to wear his contact lens anymore. If you look at the right column, you can see his uncorrected vision was he could just count fingers. If he held fingers right in front of his face, he was only able to see those. His vision with glasses was 2100. He couldn't wear a contact lens. And those numbers on the bottom, where it says -18, that's the degree of nearsightedness and astigmatism that he has, which is quite a lot. Why has he gotten bad? Well, if you look in 2008, you can see that his cornea is regular. It's actually flat in the middle because he had previous LASIK. In 2020, look what's happened. The bottom part has become very steep. So if we compare points, he was 38 diopters here, flatter than normal, and here he's 70 diopters. If you look at the difference map, which subtracts the two, you can see in one area, he is steepened by 30 diopters. So he's gone from, let's say, a normal 40 to 70 diopters of cone elevation. So we took his maps, analyzed them, and did a CTAK segment, as you see here on the right. Again, what we are measuring here is the length of the keratoconic cone, the position of the cone, and the degree of thickness that we're going to need. So this tells us what curvatures to put onto the CTAK inlay, how wide to make it, how thick to make it, and what kind of curve we should put on it. And these are actual pictures of the same patient. And if you follow the contour of the light here, you see the bulge of KC. And afterwards, if you follow that contour again, here's a CTAK segment from a side view, you can see that it's smoother and especially here, flatter than it was originally. Here you can see the corneal topography maps. Before surgery, he had a fair cone inferiorly down below. Afterwards, you can see that the central area has flattened a lot. So rather than being a lot of red, it's much flatter and is blue, as you recollect in keratoconus. And when looking at these maps, red is high, so it indicates the cone. Green is, let's call that normal, and blue is flattening. So we want to make the red colors more blue. And looking at the difference map, you can see that we had the central cornea flattened by about 10 diopters. Now, over time, the CTAK segment's clear. This is that same patient. So on day one, you can see it. But if you look at 6 months, these are the edges, but you see the tissue is quite clear. If we look at it through this slit beam, here you can see the actual segment, and here you see the clarity of the inlay. So how were his results? Recollect that preoperatively, he could only see fingers right in front of him. Afterwards, he saw 2100, which is functional vision. His glasses corrected vision improved from 2100 to 2040, and his nearsightedness improved from -18 to -8. But almost more importantly, with a contact lens, he was 20/20. We are now performing a new CTAK clinical trial. This will comprise, to start, 10 patients who can have either keratoconus or ectasia. You need to be over 18 years old. You undergo a screening examination to make sure that you're a candidate. And obviously we need to see you the day of surgery, but it's important that we see you afterwards at 1 day, 1 week, a month, 3 months, and 6 months. Now, if cross-linking is needed along with it, that will be performed after the 6-month follow-up examination. After a month, we can refit you for contact lenses or give you a new glasses prescription. And after 6 months, we can also consider further procedures such as laser correction with topography-guided PRK, or the conductive keratoplasty procedure, or something like the intraocular lens ICL procedure. So we'll now invite any questions. Here's all of our information. Should you have any questions about keratoconus in general or about CTAK in particular? So I'll turn things back now to Stacy, and I think we can take some questions at this point.
All right, so Stacy, can we hear you?
Dr. Greenstein, I think we're still seeing your show.
I don't think so because mine is closed, but let's see.
There we go. Now we're all up.
Yep. But where's Stacy? Are you there? Just
hello, Stacy.
Give us a second.
There we go.
We can't hear you.
Can't hear you.
We can see you though.
Okay, well, I do know, I know one of the things that had come up while we're waiting for Stacy to get to the more specific questions. One of the things that has come up a bunch is contact lens fitting after the CTAK segment. So, of course, our goal with the CTAK segment, as we discussed, is to reshape the cornea, creating more regular shape, which we have shown that we can actually improve vision in glasses pretty significantly with the procedure. But you know, there's always a need for potentially wearing contact lenses for kind of that next level of vision for some patients. So Dr. Gillies, why don't you discuss a little bit about kind of that fitting process? Dr. Gillies already has a lot of experience fitting over these segments, so maybe you can describe that a little bit.
Yeah. So, the CTAK procedure, basically, the most interesting question that people want to know is how quickly can we start wearing contact lenses afterwards, which is generally at the 1 month mark. The eye is healed enough, and at that point, depending on the severity of the eye or the curvature of the eye after the procedure, helps to dictate what sort of lens you can be in. Thus far, we've had no problem with getting excellent correction out of people after the procedure. Many of them more improved than they were prior to. When we fit these individuals, so far I've fit mostly scleral lenses on these individuals, but also some soft lenses as well. So the lens fitting process is not really not impeded by having this. In fact, it's a pretty simple task for doing that afterwards. Well, simple for me, but
So,
yeah.
so I think kind of the important thing there is that part of what we can do now in keratoconus management, and CTAK fits really nicely in this picture, is for some people, you may have the CTAK done, glasses start to work great, and you may not need the contact lens at all, which may be a great result. But one of the things that we've learned over time is it's also helpful to be able to kind of decrease that dependence on wearing the contact lenses 24/7. So even though you may feel like you need the contact lenses to get that kind of, like we call it, that next level vision during the day, it can be very helpful to be able to have these corneal reshaping procedures and feel functional when you wear glasses, whether that be at night, whether that be over the weekend, or just on a day that the contact lenses aren't feeling great. So this kind of bridges the gap we've found for many patients, which is they wear lenses kind of like everyone else wears lenses. They wear lenses when they feel like they want to wear lenses, when they want that vision from the lens, and then they have the option to wear glasses and still feel functional that way. So I know that Stacy is still having a little bit of technical difficulty.
I have a few questions came through to me. Maybe for Dr. Greenstein, you can answer this. So what happens if cataracts develop later on? Can cataract surgery still be accomplished?
Yeah, so that's a very good question. Cataract surgery can definitely still be accomplished after CTAK. In fact, one of the patients who we did a CTAK segment for already has had cataract surgery, and the CTAK segment helped us with that process. Cataracts are when the lens inside your eye has now become cloudy. CTAK is performed on the cornea. So the reshaping that you have done from the CTAK segment, if anything, can actually turn out to be helpful for cataract surgery because the more normal your corneal shape, the better the implant is going to work after cataract surgery. So if anything, for certain patients, this might be helpful to have done beforehand, but it's definitely not going to create a problem for doing cataract surgery down the road.
You might also discuss a bit while we're on the subject, the kinds of things that we do pre-cataract surgery in patients who have had no other procedures thus far, the kinds of things to make the cornea more regular, to make the cataract surgery better.
Sure. So again, I think cataract surgery, similar to what we just discussed, again, really kind of puts together this concept of the three components of really taking care of keratoconus, and that's stability, which we get from the cross-linking, it's corneal reshaping to get the cornea to be the most regular shape possible, and then that final correction of the prescription however we can. And cataract surgery really merges that all together really nicely. So we are now doing an offering, in particular, topography guided PRK, as well as now CTAK, which does corneal reshaping and makes the cornea as regular and as normal a shape as we can. we will then frequently do some cross-linking to stabilize the cornea. And then finally, when we have that final prescription, we will then do cataract surgery to really refine the vision further. So we can now do cataract surgery to not only replace the lens that has become cloudy, but we can actually use that implant to our advantage and correct the remaining prescription. So it really kind of bridges the gap between all three aspects of keratoconus management, and topography guided PRK in particular, and now CTAK really fits in very nicely to this, spectrum.
For Dr. Gillies, what is the preferred contact lens to use after CTAK?
Generally depends on the the severity of the individual and what their cornea looks like after the procedure. Thus far, I've been able to use both scleral lenses and soft lenses on these individuals successfully, and I would suspect that you're going to be able to use the same variety of lenses that are available, but I think successfully, in my experience so far, scleral and soft have worked well for the individuals afterwards.
Do you think there's a place for the customized wavefront lenses in these cases?
Absolutely. In fact, we've had 3 patients so far that have done the wavefront guided scleral lenses after undergoing CTAK, and they have all done very, very well with it. So yeah, that's certainly an option for them.
Another question I can answer is how long, what's the life expectancy of the inlay? We find that the longer you have it successfully, the longer we expect you to have it, because what we're implanting here is corneal collagen. We're taking a human collagen, which is completely compatible with your cornea. It's the same collagen as your cornea. It just doesn't have the cells. Your own cells will tend to migrate into the graft. So hopefully this will become a natural part of your own cornea. Certainly, if it doesn't work for some reason, it can be removed, but we hope that this is very biocompatible, and it's one of the reasons that we're excited about this type of technology compared to other things where we are using synthetic inlays and the like.
Yes. One other question which has come up is if you've already had a procedure done like Intacs, can you have the CTAK procedure done? And so the short answer is yes, but it would likely require the removal of the Intact segment first. But what we found is if the backdrop of my assumption to kind of asking that question is if somebody's already had their intact segment placed and they feel like the vision is not quite as good as they expected it to be or wanted it to be. And we really now have some multiple options to improve vision after Intacs that may not require removal and placement of a CTAK segment. We do have some patients who are actually going to have their intact segment removed and have a CTAK segment placed. But what we found is that topography guided PRK has actually served to be very, very useful in touching up people's vision and really further refining the surface of the cornea after Intacs placement. And we actually are going to be presenting on our most recent group of patients that we've done this PRK over their intact segment at one of the upcoming national meetings, and we've had really great results doing that. So I think step one, if you've had an intact segment placed but feel like the vision is not quite where you want it to be, is really having an evaluation done so we can really get to the bottom as to what is the remaining problem. If the Intacs is just not flattening the cornea enough, then CTAK might be perfect. If the intact segment is actually doing its job, but we just need to kind of take it one step further, topography guided PRK is actually most likely to be the best procedure for that.
And you remember, topography guided PRK is when we use the laser, a similar laser that we use for LASIK, but it's guided by your corneal topography. It's just you move a very little bit to get extra symmetry and extra smoothness to your cornea. Another one of our participants asked, I had a PK transplant 17 years ago in the left eye. Is it risky to try CTAK on the right eye? Well, it really depends how your right eye is and how your left eye is. If you are doing well with the current contact lens and you're seeing well, then probably CTAK is not necessary. But if you are having poor vision out of that eye, cannot wear a contact lens effectively or with good vision, or your two eyes are very imbalanced, then certainly it's something that we can consider, but it really is on a case-to-case basis. We need to evaluate both eyes. We need to assess just what your needs are so we can pick the proper procedures. And there are a lot of procedures nowadays in KC. Collagen cross-linking, intracorneal ring segments, conductive keratoplasty, which is a focal collagen shrinkage procedure, a topography-guided PRK, where again we use the laser guided by your corneal map to try to smooth it more. The intracorneal intraocular contact lens, the ICL, is something else to consider. So we have to examine you, see what's best in order to pick from our whole armamentarium which is best for you and what combination of things might be best for you. It's an iterative process. We're trying to make you better. We want to be as safe as we possibly can, but it might be that more than one procedure is helpful over time. Or as you get older, there are other procedures that might be beneficial to you as your vision changes. For instance, as you develop cataract, or if there's any change in your cornea. So again, take-home message here is, everybody's different. We need to evaluate you to pick just the right thing to do. Another question is, how long does the procedure take?
So the procedure itself really takes about 25 minutes once you come sort of into the room, start to finish. The procedure for each patient is really the two steps. The tissue has already been prepared and cut to the customized specs that we want. So it's really the two process. The laser channel needs to be created, and the laser itself creates that channel in less than 30 seconds. So it is very, very quick. It is very, very accurate. Most of the time, like a lot of these procedures, is actually spent kind of getting the eye ready for the laser, getting things positioned and centered properly. And then the tissue placement itself, probably takes another 10 minutes or so from start to finish. So from the time you come in to the time you leave is probably about 25 minutes total. It's all done with numbing drops. You don't feel the procedure happening at all. There's really no sharp instruments used at this point for the procedure because the laser is creating all of the cuts and the channel for us. So everything is really done blunt with blunt instruments. Kind of piggybacking off of that, because I saw another question, was the healing process for the CTAK procedure. And this also sort of breaks down into two areas. When the CTAK segment is placed, it creates a pretty large change to the cornea, as we have shown with the pictures. And so with that significant change and that significant amount of flattening, it really creates a very large change in your prescription. Now that happens almost instantaneously, but there is a little bit of inflammation and a little bit of swelling right after the procedure, which takes about 4 to 7 days to kind of mostly heal up. And so we don't really, and that's why we wrote, we don't really check your prescription for about a month. Within the first month, we're able to kind of recheck your prescription, give you whether it's a temporary contact lens or glasses. And then, like everything when it comes to corneal procedures, there's usually a slow remodeling that happens over the first 6 months. That's not so important to the changes in your glasses prescription, although that will change a little bit over time. But it's very important for the next procedure that we might do. And that's why 6 months is really an important time frame before we make the next decision about whether something like laser vision correction, an implantable lens, or a conductive keratoplasty might work for you. Dr. Gellers, do you want to just kind of give a little bit on the process of fitting a lens in that time frame?
Yes, yeah, actually that's a nice segue into into one very important point, which is that because the change that you make to the cornea with this procedure is very large, and it can have a big impact on the way a contact lens fits, it's important to know that the contact lens that you currently wear is not going to be the same parameters or shape as the one that you're going to need after the procedure. So really at that 1 month mark, that's when we should be doing a contact lens fit for you. Because one, at that point, we can start to accommodate the new fit, and we can also, or the new shape of the eye with an updated fit of the contact lens, but also improve the vision for that time.
Another question is there pain after the procedure?
So what we found, everybody's perception of pain can be a little bit different after any procedure, but with this procedure, we have not found that there has been significant discomfort afterwards. You will feel a little bit light sensitive. You'll feel some scratchiness in the eye afterwards, for sure. We do place a contact lens, which acts as a Band-Aid over the cornea, usually just for the first day, which helps with kind of that immediate discomfort. And usually after about the first 24 hours, as that scratchiness wears off, the discomfort is generally very minimal.
Another question is, how is the cornea anesthetized? Well, we use topical numbing drops, which are quite effective. And you also get a mild sedative just to take the edge off beforehand. So most patients are quite comfortable during the procedure.
So I know we're getting close to kind of that cutoff point, and we did say we'd run over a little if we had a lot of questions. There were 2 trial specific questions which we may want to touch on. One was, is the trial only happening in New Jersey? Do you have to be in New Jersey to participate in the trial? Dr. Hersh, do you want to take that one? Or?
Well, it's only at our center that we're doing it. And if one can travel, we're seeing patients from all over the country. But you do need to be available for those follow-up visits because that's important information that we're using for this clinical trial.
Yes, and just a second question, and you can definitely email Stacy after the presentation. She can go over a lot more of the particulars, but as we did discuss in the presentation, these first 10 patients that are going to participate specifically in this Cornea Gen partnership trial that we have begun are going to be sponsored for the procedure. So that will be for at least the first 10 patients that are part of the CTAK, the upcoming Cornea Gen CTAK trial.
Another question is, can CTAK be performed on both eyes at the same time? Generally, we suggest not. We like to see how the first eye responds because we can always learn something from that to see if we have to change anything on the second eye.
And I think that question gets asked a lot about a lot of the procedures that we do for keratoconus. And one thing we try to do, there are definitely certain circumstances when it comes to cross-linking or other things that we do the procedures on the same day in both eyes. But we do stress to patients that we want you to be as functional as possible through the early healing period of any of these procedures. And you have to remember, once a procedure like CTAK is done, for that first month, you're really not going to, your old contact lenses your old glasses are not going to work. It's a guarantee. The prescription is going to be very, very different. So if that is done on both eyes at the same time, functionally, you won't have a pair of contact lenses or glasses to be able to do work, to be able to do your kind of normal activities. If you just do one eye at a time, you can still use your contact lens or glasses in the other eye and really maintain, fairly normal function through the healing process. So this is really true when it comes to a lot of procedures that we do for keratoconus. We really recommend going one eye at a time.
Some people have asked, can you have CTAK with Intacs in?
Yeah, so, again, we sort of had touched on that a little bit before. We don't recommend putting the CTAK segment in if your current Intact segment is in the cornea. We have had patients that we have advocated removing the Intact segment and replacing it with a CTAK segment, which may have certain advantages because of the increased flattening and the customization we can achieve with the CTAK segment. But also, like we talked about a little bit before, the first step, if you already had an Intact segment in place, would definitely be to have a initial evaluation to see what the remaining problem is, because there may be other procedures like a topography guided PRK that actually improves your vision more than removing the first segment and replacing it with a CTAK segment.
If you have had Intacs, though, and they're not doing quite the job that we want them to do because they are not supplying enough change, then often those can be changed for a CTAK procedure potentially.
Absolutely. So I think we've kind of hit our 1 hour mark and kind of gone a little over. We tried to, because this is such a new procedure, we did want to get to as many questions as we could. If we couldn't answer your question tonight, please feel free to email us at info@vision-institute.com, and we'll definitely try to get to any remaining questions that you have. And really the next most important step is the screening and to determine if you are a candidate to have the CTAK procedure done, and we can discuss that in more detail as well. So anybody else have any closing remarks?
Well, thank you all for attending, and we look forward to seeing you on our next webinar shortly.
Absolutely. Thank you very much.
Good night, everybody.
Take care.